Okay, so let's continue. So we have got three pairs of salivary glands. The first one is called as parotid, and the second one is called as submandibular. Okay, and the third one is called sublingual. The sublingual is mostly mucus. Okay, so this is a mucus. Okay, and this one submandibular is mixed, both mucus plus serous, and this parotid is serous. Serous means a liquid fluid secreting, and this sublingual means mostly mucus secreting. Okay, so you secrete mucus under the tongue, okay, and you secrete fluids or clear fluids in the carotid gland. But submandibular, it is the all-rounder. It secretes both serous plus mucus, so it is mixed. Okay, so it will give you stones. Okay, but the parotid will give you tumors. Okay, now let's move further. So basically, the tumors are 80% contributed by the carotid gland. Okay, and these are pleomorphic adenomas, and 80% of the pleomorphic. Pleo means many, or morphic means structure. Pleomorphic adenomas. Okay, and 80% are superficial lobe. Okay, there are some lobes in the parotid gland, so superficial lobe is mostly involved in tumors. Okay, and most of the tumors are pleomorphic adenomas. Okay, now malignant is rare. Okay, whenever you see a patient that is having some short history. Okay, whenever you see a patient with a short history, now I will tell you what could be malignant. Okay, what could give you malignant? When a patient comes with a short history, okay, and when a patient comes with a painful, okay, hot skin, and if you see and there is heart tumor, I'm talking about the tumors, malignant tumors. Okay, so and when they involve the cranial nerve 7, which is the facial nerve. Okay, and they are fixed, so these all can tell you that the patient is having malignant tumor. Okay, short history, very fast and painful. Hot skin will be there, and there will be heart tumor. It will invade into cranial nerve 7, and it will be fixed. Okay, now talking about the pleomorphic adenomas. Okay, pleomorphic adenomas. Pleomorphic adenomas are benign. Okay, benign mostly, and they are mixed parotid tumors. Okay, so they will be slow growing. These are mostly benign, so benign are slow growing tumors. They will be painless like all the tumors. Okay, and they will be they can go into the transformation into malignant. Okay, they are dangerous in a sense that they can transform into malignant. Now the treatment involves the superficial periodictomy. Whenever you see a pleomorphic adenoma, okay, which is 80% of the times tumor in the parotid gland. Okay, and this parotid gland will give you serous fluid. So whenever you come across a pleomorphic adenoma, it will be benign, it will be slow growing, it will be painless. Okay, it will be painless like all the other tumors, but it can transform into malignant. That's why it is a bit dangerous. Okay, so what you have to do is you have to do superficial parotidectomy. Okay, so you have to remove the superficial part. Why? Because I told you that it has multiple lobes. The parotid gland has multiple lobes, but the superficial lobe is mostly the lobe which involves the tumors. Okay, which which give space to the tumors. And which tumor is the most common in the parotid gland? That is the pleomorphic. Okay, the pleomorphic tumor is the pleomorphic adenomas are the most common, 80% common parotid tumors in the salivary glands. Okay, and what are the features of pleomorphic? It is benign, slow growing, paleness, and you have to do superficial periodictomy. Why? To remove the superficial lobe, and along with the superficial lobe, you will remove the pleomorphic adenoma, and these can transform into malignant. Okay, so this is it. Now let's move to the another one, which is called as warthin. Warthin. These are also benign tumors, okay, but these are 10%. Now mostly these two, you have to remember only these two, okay. One is called as pleomorphic, which is most of the time, 80% of the time present. It is very common. And then the other one is warthin tumor. They both are present in the hair. Okay, so warthin tumors are 10%. Okay, they are benign. Okay, they are present in males, and they can be softer. They are soft. Okay, and they are mobile. Okay, they are mobile, and they are fluctuant. Okay, fluctuant. So they are more mobile. They are more soft. They are more fluctuant, but they are very less, 10%. These are called as warthin tumors. Now, talking about the stones, let's talk about the stones. Okay, stones are recurrent. Stones are here. Okay, now I'm talking about the submandibular one. Okay. Okay. Let's talk about the submandibular. Okay, now what is submandibular? Okay, submandibular, I told you they have a mixed secretion. They are serous plus they secrete mucus. So submandible are located below the mandibles, okay, below the mandible, and they produce serous plus mucus. And when parasympathetic activity is dominant, the secretion will be more serous. Now, if you are under the pressure of parasympathetic system, which is rest and digest. Okay, you have had a meal and now you want to rest and only digest this meal. So this submandibular will secrete a lot of serous gland. Okay, and when the parasympathetic fibers are derived from the cauda tympani nerve and the submandibular ganglion. Now let's move further. Now I want to talk about the exam point of view. Okay, the exam point of view, one is called as silolithiasis. Silolithiasis. It means that there is stone, okay, in the submandibular area. Now 80% of all salivary glands calculi occur in the submandibular. All the stones, 80% of the stones. 80% of the stones which are present in the salivary glands occurs in submandibular area. Okay, first thing. And around 70% of these calculi are radio opaque. So these can be seen through X-rays. Okay, and the composition is calcium phosphate and calcium carbonate. Now the patient will typically develop colicky pain and postprandial swelling of the gland, because I told you whenever you eat, okay, and you want to rest and digest, the parasympathetic will pressurize the submandibular gland to release some serous. Okay, so after, because now you are having a stone which is stuck in the submandibular gland, okay, now you cannot produce the serous fluid. So what will happen, that after having a meal, you will develop some pain. Why? Because the serous will try to come out of the gland, but because of the stone stuck in its pathway, it cannot come out. So you will see some pain after the having a meal. Okay, and as well as the patient will have some postprandial swelling. Swelling will be seen in the submandibular area. This means that serous is being produced, but it cannot come out. Okay. let's move further. So what will happen? So you have to investigate this patient. You have to investigate this patient. So investigation involves silography. There is one method which is called a silography. Silography. So you will have to do silography to demonstrate the site of obstruction and associated with other stone. So this silography will show you where exactly the stone is location, okay, and the stone type, what kind of stone it is, okay. So the stone impacted in the distal aspect of the duct can be removed orally. So now there are different positions, okay. One is there opening at the oral cavity. So the one which are the stone which are present at the side of the oral cavity, they can be removed out through oral cavity, and the one which is present here, okay, they could be removed through gland excision, okay. Now whenever the stone is stuck in the pathway or in the pathway of the submandibular gland, it will lead to inflammation, okay, it will lead to inflammation, and this inflammation will be chronic, okay. So that's why these stones can lead to chronic silolithiasis. Now the next one is sialadenitis. Sialadenitis is, now I'm talking about the sialadenitis. Sialadenitis is an inflammation of the salivary gland. It is simple inflammation, and this can be acute or chronic. And the patient suffering from the sialadenitis usually experience swelling. So whenever you come across swelling, let me change the color. So whenever you come across a swelling, okay, now I'm talking about the sialadenitis, which is inflammation of the salivary gland. So the patient will experience redness, swelling, and pain in the mouth. So the bacteria or because of the bacteria or virus, okay. So you see, one is chronic inflammation because of the stone, and the other is the acute inflammation, or it could be chronic because of bacteria or virus. So the bacteria and virus one is called a sialadenitis, and because of the stone, it is called a silolithiasis, okay. Now about the sialadenitis, oftentimes people are confused, okay, what is sialadenitis? So in the sialadenitis, because the inflammation is from the bacteria or virus, okay, so there you can see that there will be swelling, okay, swelling, edema, and because of the infection, you will have bad taste, because of from the pus, okay. Pus will lead to bad taste, and there will be pain, there will be swelling, there will be redness in the skin. This is called a sialadenitis. And there will be dry mouth, okay, and there will be shortness of breath, and there will be deltal pain. So this antibody, and bacteria will involve the whole space in the mouth, and it will have systematic problems as well, okay. Now this is it. So there are two types of sialadenitis. One is acute and one is chronic, okay. The chronic is less painful, okay, and the acute one is more painful. And in acute, there will be erythema, pain, tender swelling, palpation. On palpation, there will be swelling, okay, and there will be overgrowth of the oral flora. The normal flora which are present in the mouth, it will increase its flora. So there will be overgrowth of the normal flora, and mostly the patient will present to you after post surgery, okay, post surgery or post operative, because you know that the patient is prohibited from eating or drinking when he is going to perform any surgery. So after the surgery, because of his mouth is becoming so dry that post operatively he begin his oral flora is much increased, okay, which leads to infection of this submandibular gland, and it is called as acute sialadenitis. Okay, so there will be bad taste, there will be smelling of his mouth, and there will be purulent discharge coming from the mouth. Okay, and what about the chronic one? The chronic one is less painful. Okay, and the chronic one occurs again and again. Okay, so there will be recurrent enlargement. So there will be recurrent enlargement often after the meals, and usually without erythema. Okay, and there will be associated with the condition affiliated to reduce salivary flow. Okay, so there the condition are different here. Okay, the condition are different here, not because of the dehydration, but because of the reduced salivary flow. So here there might be problem with the salivary flow. So the saliva is not coming off very regularly or very good in sufficient amount. So you will have chronic sialidosis, and so the normal flora will try to increase, and it will try to create sialidosis. And this can also be because of the silolithiasis. So suppose if the patient is having a stone stuck in his pathway, submandibular gland, and he cannot reduce the serous fluid. Okay, so again and again there will be chronic inflammation. One time it will open, and again it will be blocked. So this is called as chronic sialidosis, and it can be because of the silolithiasis. There will be less pain, it will have recurrent, and mostly it doesn't depend on the dehydration. Mostly it is associated because of the disturbed flow of the saliva. So I hope it's clear now. Now let's move. Here you can see this is carotid gland, this is submandibular, and this is sublingual gland. Okay. Okay, let's move further. Chronic, did we talk about the chronic? No. Here you can see chronic sialidosis, inflammation of the salivary gland, which is chronic. It occurs again and again. It is often secondary to silolithiasis. Why? Because there is stone blockage of the gland, which leads to decreased salivary outflow. Okay. So swelling will be there in the region which can become enormously large. The swelling is more painful and prominent on chewing. Okay, this leads to obstruction due to salivary stones. Why? Because I told you, because of the parasympathetic system, parasympathetic will urge the salivary glands, all the salivary glands, to produce more serous fluid, and because they have stones in their pathway, so they cannot release it. So rather what will happen, that they will try to release the saliva or serous fluid, but because of the obstruction there will be swelling in the glands. Okay, and there will be pain after eating a meal. So there will be prominent on chewing and painful. Obstruction due to salivary stones and tenderness and redness, sore taste in the mouth, no saliva, dry mouth, no saliva. Okay, so dry mouth is basically in acute sialidosis, and that is post-surgical, okay, procedure. Now, decreased mobility of the jaw. Okay, there will be decreased mobility because of the infection. If got infected, there will be fever and rigors, may cause septicemia. What are the differentials? The differential could be Mikulicz syndrome. What is Mikulicz? It is a symmetrical enlargement of all salivary glands, like submandibular and sublingual and parotid. So one side and the other side. So both will be try increased symmetrically. Okay, and there will be narrowing of the palpebral fissures due to enlargement of the lacrimal glands. Okay, in the lacrimal glands, there will be narrowing of the palpebral fissures. Okay, because your lacrimal glands, these are also glands. Okay, so these are, so the lacrimal glands which are present in the eyes. Okay, they will also be large. They will also be large. So the palpebral fissure, which is from one eye to another, it will decrease. Okay, the space will decrease. Okay, so it may occur secondary to sarcoidosis, okay, and tuberculosis or lymphoma. Okay, Now the next thing is in a patient with epistaxis, the normal naps, normal HB and platelets. This is another topic, okay? So you can suspect anatomical defect. Why? Because everything is normal. The only abnormal could be anatomical defect or trauma, or he might have suffered some trauma. That's why he might be having epistaxis or bleeding from his nose. Note, trauma to the nose is most common cause of epistaxis. It includes nose picking, excessive nose bleeding, and foreign body insertion. So in all these cases, you can have epistaxis. Now, what is meniere disease? Okay, so let's move further. Okay, so let me briefly tell you what meniere disease is. Okay, so 1 second. So suppose I am taking this semicircular canal out, okay, and there are three semicircular canals. Okay, I am taking out the posterior semicircular canal. Okay, posterior semicircular canal, or anyone. Okay, just forget the posterior semicircular. I am telling you about the semicircular canal. Okay. So what happens is in semicircular canal, there are three parts. Okay. So suppose this is your semicircular canal. Okay. This is one part. This is the another part, and this is the third part. Actually, they are rounded in round shape. They are in round shape. Okay. What happens is this. Okay. This one is called as perilymph. This one and this one. These two are called as perilymph. These two are called as perilymph. This one, the inner one, is called endolymph. Okay. So there is basically fluid inside them, okay? And this fluid determines the type of sounds that they are hearing, okay? Now, when the sound waves come towards them, okay, they generate the air fluid pressure, okay? And this air fluid pressure is sensed by the hair cells, which are present in the, so suppose, look, when fluid is flowing against them, they stimulate the hair cell which are present here, okay? So these hair cells are basically connected to the vestibulocochlear nerve or cranial nerve 8. So this cranial nerve 8 will go to the brain and it will form the sound which you are hearing. So different patterns of fluid coming through the this semicircular canal can generate different types of sound. Okay. Now, so the endolymph, these two are endolymph, and the one which is in the middle is called as endolymph, and the other two are called as perilymph. Okay. So there will be increase endolymph. Okay. So suppose if you come across a pathology, okay, so if due to some reason you come across a pathology where you produce excessive amount of endolymph, okay, where you produce excessive amount of endolymph, so it will slowly bulge into the perilymph, and it will further bulge into perilymph, and lastly it is stretching. You can see here, this is a vestibular membrane. This part is called as vestibular membrane. So it is stretching the vestibular membrane into the perilymph, and lastly, at last, consequently, it just ruptures this vestibular membrane. And when it ruptures the vestibular membrane, they both are connected together. Okay, these both are connected together. But because because the endolymph is being excessively produced, so because of the high pressure, the body may perceive it as something is as the head is moving. Okay, because of the head is movement, we are getting the signals, but that is false. Okay, you are not having any head movements, rather your endolymph is being excessively produced in the hair, in the endolymph. So it will stretch on the vestibular membrane, and it will eventually rupture this vestibular membrane, and all the fluids will communicate into the perilymph. So the end result is that you get a lot of the fluid inside your semicircular canals, and a lot of excessive fluid in the, which is called as endolymph. Excessive fluid can result into three things. Okay, three things that are called as DVT. One is deafness, the other one is vertigo, and the third one is tinnitus. Okay, these three things will be present because of the excessive fluid, and these excessive fluid will stimulate the hair cells excessively, and the hair cell will eventually give the vestibulocochlear nerve the perception that we are either the head is moving, okay, but the head might not be moving, or you are having excessively perceiving sounds or something. Okay, so in meniere disease, whenever you see these three symptoms, okay, you just tell them that you are suffering from meniere disease. Now here you can see endolymphatic sac or acoustic nerves, okay, and normal. So normal endolymph is very little in amount, you can see, but here you can see there is bulging of the endolymph. Why? Because of the excessive endolymph which is being produced. Okay, so there will be tinnitus, fullness, and when the vestibular membrane ruptures, the fluid will mix and the vertigo occurs. But the good thing is that eventually the pressure will wean off, and the vestibular membrane will heal itself again. Okay, so this is the meniere disease. Okay, here you can see, look, this is vestibulocochlear nerve. So the vestibulocochlear nerve is giving signals. The semicircular canals are giving signals to vestibulocochlear nerve. So if the if fluid is more, there will be excessive stimulation of the vestibulocochlear nerve. Look, backed up fluid leads to swelling and pressure. So the swelling, it distorts the balance information, and swelling distorts sound information, and distorted information travels to the brain. So there will be brain balance and sound distortion. Now look, DVT plus fullness. What is DVT? DVT is deafness, which is sensory neural hearing loss, unilateral, vertigo, tinnitus. Whenever these three things are present, DVT, you suspect meniere disease. Okay. And lastly, fullness. Nausea, vomiting can also be there. Lasts from minute to hours. Okay, from minute to hours. The time period is very crucial. Okay, very important to remember. So you have to remember it lasts from minutes to hours. What you have to give is prochlorperazine, buccal or iron. Promethazine, cyclazine, cinnarizine, you can give. Okay, so the first line is prochlorperazine, or you can give promethazine, all the zines. Look, procyclazine, cinnarizine, or promethazine. These are antiemetic agents. The feeling of pressure inside an air may not always be given. Important note: feeling of fullness, pressure in the affected air. Look, I will tell you briefly. Just DVT for in minutes to hours. This is meniere disease. Okay. So feeling of fullness of the pressure. Fullness is because of the endolymph, excessive endolymph. Okay, pressure in the affected line is more classic for meniere disease. However, there are other symptoms of cranial nerve involvement, diplopia, facial drooping sensation, a likely diagnosis with acoustic neuroma. This I will tell you in next week. So MRI is normal. MRI may be normal, which exclude acoustic neuroma. I will tell you about this. Labyrinthitis is usually preceded by viral. I will tell you about this again. So I have already explained all these. Okay. Weber electrolysis to left. Okay. Okay, so what you have to do is do MRI scan careful, not otoscopy. Okay. Why? Because in otoscopy you cannot find out what is going on in the inner ear. So if the patient presents with a hearing loss and found to have SNL, sensory neural hearing or Renner test and Weber test, AC is greater than BC. Okay, this is a normal. This is a normal test. Weber electrolyzes to one side. It means which side it is electrolyzing? To the normal side. Okay, So you have to order MRI. This is DVT plus minutes to hours. This is meniere disease. So what you have to do is MRI. Here you can see, okay, this is another topic. Okay, so very little time is remaining. So we will do the next further remaining in the next tomorrow. Okay, I hope you people understood. I tried.
Yes, can I ask a question?
Yes.
Okay, please, can you explain, sorry for bringing you back,
No problem.
the
What?
bleeding in nose, the nasal packing, and
Okay.
when to use nasal pack and cautery. I got confused there.
Okay, no problem. Okay, so first thing is that it will come further, but to tell you briefly, I will tell you that. Okay, let me bring up the topic. Yeah, here it is. So, okay, let me tell you briefly. So, if there is active bleeding, okay, active bleeding, anywhere when you see active bleeding, you just have to do anterior nasal packing, okay. And if there is recurrent bleeding, okay, but now there is no active bleeding, okay, now there is no active bleeding, then you will have to use topical treatment like chlorhexidine or neomycin, okay. When there is recurrent bleeding but no active bleed now, okay, so what you will do, you will observe, you will see that there are some vessels, okay, which can be seen, there are some vessels which can be seen, okay, in the inferior, in the interior inferior portion, in the interior, this is called the little's area, okay. Here the most of the blood vessels are lying together. So when vessels are seen and but there is no active bleeding, but this patient comes to you and he is having recurrent bleeding episodes, and now you have got the chance to do a procedure which is called as cautery. Cautery is basically burning the vessels. Okay, so you will burn the vessels out. Okay, so you will burn the vessels on one side. Okay, there are no active bleeding, but this patient is suffering from recurrent episodes of bleeding. Now you have got the chance, when you observe his nasal cavity, you can see some vessels, and these vessels are on the verge of bleeding again. So what you do is you do the nasal cautery, okay, on one side, okay. Then you tell him to come next day and you do the next side, okay, not both on the same day. Why? Because of the rupture of the nasal septum, okay, because because cautery is basically burning out, okay, the procedure of burning out, so you can burn out the nasal septum, okay. Or you can do another stuff which is called as topical procedure, okay. In topical there is chlorhexidine, okay, or this one, chlorhexidine or neomycin cream, okay, you can give them. Why you cannot use the cautery? Why you cannot use cautery on the active bleeding? Because there is a substance, okay, which is called as silver nitrate, because the silver nitrate is used to proceed with the nasal cautery, and you cannot risk the silver nitrate. Why? Because it can be washed out when there is active bleeding, okay. And there you can see the anterior nasal bleeding. Yes, anterior nasal bleeding will be left for 24 to 48 hours. And what you will do in active bleeding? In active bleeding, you will do nasal packing, And before, if they ask you what is the initial test, so the initial test would be to pinch the nose, okay, for some minutes, like I think 10 to 18 minutes or something, okay. And which portion you have to pinch? The little area, okay, which come into interior and inferior part. But you have to lean forward, okay, lean forward and pinch the nose for 10 to 18 minutes. And then if it is still not affecting, then you should go for interior nasal vacuum. And when the episodes are recurrent, you should then go for the cautery. Any other question?
All right, thank you.
You're welcome. Okay, so the further lectures will be given the next day. Okay. Thank you so much for attending.
Thank you too.